My name is Chip Lyons. I'm the president and CEO of the Glaser Pediatric AIDS Foundation. And as I think you know, we are marking our 25th anniversary as a foundation. We will find appropriate ways, and we have a multitude of things to celebrate around the anniversary. But we thought, in kind of the early tradition of the foundation, we really should use the occasion to bring people together, relatively small groups of thinkers and leaders, to really lay out what ought to be the next steps, the priorities, where are the opportunities. We're at a remarkable place in 2014. On the one hand, it might be bookended a little bit with the semi-arbitrary 2015, the dates for the Millennium Development Goals, and certainly the date to achieve the virtual elimination of pediatric AIDS according to the global plan. But I think everyone in this room that has done as much work as you all have know that 2015 does not mark the end of anything. It marks a calendar date where goals were tied. There's a considerable amount of work that lies ahead of us, and yet we're in a context of substantial but clearly finite resources. And depending on who you talk to, those will stay flat. They could decline. We have achieved remarkable things, largely due to PEPFAR and the Global Fund in terms of financing and strategy mechanisms, but certainly as a result of governments, ministries of health, the frontline workers that do a great deal of the work. Tremendous progress that you'll both hear about, you already know a considerable amount about. And yet, here we are. There are tremendous challenges still ahead of us. The number of kids that are on treatment, only a third that are eligible for treatment of the 3.3 that are living with the virus. That's just unacceptable. And if you add in the mortality rates at age 2 of 50%, age 5 of 80%, there is an urgency that sometimes is missing. And one of our challenges, and I think for everyone, is to fight any sense of complacency, particularly if it derives from a sense that we've accomplished everything that we need to accomplish. That just is not the case. The foundation, our mission is to end AIDS in children, and it started with Elizabeth's focus on her own health and her children's health. You may know that Ariel and Jake contracted the virus perinatally, and it was Elizabeth's mission in starting the foundation to get the attention of policymakers to push a research agenda that was wholly missing at that time, and fundamentally to get medication and support for her children. Ariel passed in 1988, and before Elizabeth succumbed, she, as much as almost any single person, helped change the understanding, the conversation, even made the face of AIDS, if I can put it that way, a more complete and complex one because of the effect it was having on families in the United States and eventually around the world. She succeeded in a very profound way, both in terms of her contributions in the United States, but in the form of one young, handsome fellow called Jake Glaser. Jake, would you stand up for a second? Because I don't know that everyone has had a chance to meet you. Jake has gone on to have his own career. He's a remarkable advocate in his own right. He continues to do work with EGPAF, of course, and we're just happy to have you here. Jake is a part of our 25th anniversary celebration. Elizabeth and others that she worked with early on would have never imagined that the legacy would extend to saving hundreds of thousands of children's lives. EGPAF's reach, we're in 14 countries, we're about 1,000 staff, we support over 7,000 sites, we're a leading implementation partner with PEPFAR, working closely with CDC, USAID, working within their strategic direction and financing and funding, as I said, as an implementation partner. And so the questions for us are the questions I think you ask of yourselves. What next? We're at this remarkable point. In the last number of months, I think there's been a great deal of attention on the progress, the reduced new infections down to 700 a day, but it's still 700 a day, and that's a 50% reduction over the last 10 years. Where do we go from here? And we have Ambassador Birx with us, who is 2 months in the role of PEPFAR coordinator, but has a huge and stunning career behind her and inside of her, and most importantly in her head, in the most remarkable ways that is critically important to providing leadership over the next months and years, so that we close the treatment gap between kids and adults. We do more in terms of getting a better outcome from the PMTCT cascade, about which I know you'll hear, and how we better blend the combination of investments. If we're living in a period of finite resources, what do we do? Where do we go? How do we blend PEPFAR, the Global Fund? How do we blend and integrate services? How do we blend and integrate tremendous philanthropic resources that are available that I know Pete can refer to in the one case of the Children's Investment Fund Foundation? So those are the topics. I want to thank the panelists who so readily and quickly agreed to join us. I want to thank Google as the underwriter. It's terrific to partner with Google, and they're responsible for helping us be together. And I want to introduce and hand over to our moderator for the morning for both panels and the conversation following the second panel, to Michael Gerson. I will only say that I can't stress enough the leadership that Mike has provided as an early advocate for PEPFAR, as a senior aide to President Bush. And I would say this whether you were here or not, I find the most compelling writer about HIV and AIDS, what's been accomplished. I'd read it even if it was a blog meant for one person. I think it matters that it happens to be published in the Washington Post. So, Mike, I will turn it over to you. I thank you all again for giving us your time this morning. Administrator Shah is going to be here momentarily. He's 3 minutes later than he said he would be, but I trust that he'll come flying through the doors. And we'll go ahead with the first panel. So, Mike, over to you. Thanks again for being here.
Thank you, Chip. That's much appreciated. As he said, I'm Michael Gerson. I'm pleased to be an employee in the news industry, which is temporary nowadays. I'm proud to be associated with the One campaign, a truly nonpartisan voice in the fight against extreme poverty and preventable disease. I'm truly honored to be with so many people who devote their extraordinary talent and energy and idealism to helping the most vulnerable people on the planet. And I thank the Elizabeth Glaser Foundation for convening us today. I don't come from a global health background, which may be a little too obvious today. I was a domestic policy person on Capitol Hill for many years. I took my first eye-opening trips to sub-Saharan Africa as PEPFAR was first being implemented, along with Mark Dyball, who was my guide and became my friend. So let me start with one story. Early on, Mark and I visited a clinic in Namibia where we met a family in which a mother and father were both HIV positive and had a little girl who was also found to be HIV positive. The mother had discovered this at a point when there was essentially no hope. So she named her daughter in the local language, "There is no good in the world." It was hard for me to even imagine the despair and anger of a mother who names her daughter, "There is no good in the world." It must have seemed so true to her, but actually it wasn't. When I met that family, all three were on ARVs, and the little girl was darting around my legs. And all of you are used to such things, but seeing that miracle changed me. And you are involved in the daily generation of miracles like that. This work is a great success of science as a humane enterprise, It's the success of a generous conception of America's role in the world, and it's a success of bipartisan purpose in a time of bitter division in Washington. But this success, of course, is not nearly complete, and the youngest patients involve some of the largest obstacles. We'll probably hear many figures today, but they bear repeating. Perhaps 3 million children living with HIV, at least 2 million without access to ARVs, much lower rates of treatment for children than adults. Anyone who's visited these places has seen some of the challenges. Children are harder to identify and diagnose. The treatment can be bitter or complicated. Health workers are sometimes unprepared for their needs. They can be undernourished, making it harder to tolerate the ARVs. And lifelong treatment, it raises issues of adherence and resistance that we're just now beginning to understand. I've visited, for example, a community center for HIV-positive teens in Uganda, and it's hard to imagine the added layers of trauma that being HIV positive has on top of the normal challenges of adolescence. And the added power of stigma at this fragile stage of development is really a tremendous burden. Dating with HIV, marriage with HIV, bearing children with HIV. And when I talked to Mark Dybwall last night, he urged me to add one issue to the mix, preventing young women from being HIV positive in the first place. Adolescent girls and young women are subject to violence and abuse and inequality that fuels rates sometimes as high as 5 times greater than boys and young men, and that's doubly unjust, and it must be stopped. Our focus today, however, is on what works. The best prevention, the best technological innovation, the best new drug formulations, the possibilities of vaccines and long-lasting ARVs. I recently sat down with Ambassador Birx and had an extraordinarily hopeful conversation about the next steps. It now seems really possible, armed with good data and good science, to begin interrupting the sexual networks that drive new infections, to focus on the groups and regions with the highest prevalence, and to bend the curve of new infections downward to more sustainable levels. With that kind of vision and outcomes, proven outcomes, I will tell you, speaking just for myself, that PEPFAR deserves an increase in resources, not a cut. My main job, however, is to get out of the way and let some extraordinary people speak. I don't need to tell you how extraordinary they are, and that information is in the bios, so I'll minimize the introductions. But our first panel really has some of the leading experts on disease and development in the world. So let me start with the same question for each of you. What kind of investment do you think will have the most impact on the pediatric AIDS epidemic over the next 5 or 10 years? Ambassador, you want to start?
So, as usual, I never do what I'm supposed to do, and I won't now. But I'll get to that in just a minute, because I just want to start with 2 things. One, and it's good to see Merlin Robb here, because when we were in Department of Defense together, and we were absolutely overwhelmed in 1985 with the number of positive individual soldiers, the children and the pediatric groups were slow to come forward. The mothers didn't want to bring them forward. They didn't want them to be identified. But when Elizabeth Glaser stood up with her family, it told all the other families how important that was. And we got children, and Merlin has children that are alive today. They're in their 20s, maybe almost 30. We are getting so old. And they're alive today in the United States because of Elizabeth Glaser that took that bold step. Now, fast forward to 1998. Merlin and I are again walking around Africa trying to figure out what to do. And we started a series of field sites in Uganda, Kenya, and Tanzania. And they were supposed to be for HIV vaccines. But we got to this hospital in Kericho where there was one medical officer, an amazing matron, serving a community of 1.5 million. And we had nothing but high-tech equipment and amazing ability to do T cells and proliferation and cytotoxicity, and we had nothing for the community. who came day after day and were turned away day after day. And we went to the Elizabeth Glaser Foundation. And, you know, they'd never been approached by the Department of Defense. That scares everybody right away. One, we're in uniform. What are we doing out there? What are you doing? But it was all, you know, I was very concerned about what we were asking for. But they took a chance on us. And they were the first group in 1998 and 1999 who gave us funding for prevention of mother-to-child transmission. And what started as 1,000 moms became 40,000 moms within the first 12 months to 15 months. Now that's because of Fred Zaway, who got everybody together in a distance through over 100 miles and said, we're going to do this and we're going to do it together. And Elizabeth Glaser partnered with us to make that happen. So it wasn't just that they identified the issues in the United States. They were one of the first groups that recognized the global pandemic. When the rest of us, before Global Fund, before PEPFAR, Elizabeth Glaser was there saving babies. And it's just, I have to start with that because it really was a profound experience for those of us who were out there and desperate. We were desperate to do something, and we didn't have anything to do it with. So thank you. So how should we concentrate resources? So, and where could we have the biggest impact? I think we've learned a valuable lesson with the rollout of B&B Plus. And we've seen in countries that have done that mothers, when they feel like their care is provided and that they're giving non-stigmatizing, open, transparent care in a healthcare clinic, they bring their children back. They bring back their under 2s for early infant diagnosis, and they bring back their under 2 months for early infant diagnosis, and they bring back their only under 2 years. And so in this time of budget constraints, we've challenged all of our programs to work on this rollout, but more importantly, in every country, to work with the clinics to ensure if we've identified the mothers and fathers, we have to get the children in. We cannot be at 80% coverage for adults and 35% for children when we're seeing those adults. So we're sending out positive messages as well as Elizabeth Glaser did years ago, and challenging people to step it up and do things differently and improve things. But we're also going to work on funding those higher prevalence areas to ensure that we're getting resources for that comprehensive interventions in the places where there's highest prevalence.
Chip.
Yeah. It's hard to narrow it down to one or two things just because of the complexity. And I like the way you put it, Mike, that the youngest patients represent some of the largest obstacles. At a more macro level, I think the investments need to be aimed at further scaling of care and treatment. That's a fairly broad shot notion, and it would require either exquisite targeting that Ambassador Birx is talking about, or additional resources, be they from PEPFAR or the Global Fund, or as I was saying earlier, as they get blended from philanthropy and the private sector. But narrowing it down a little bit more, we simply have to do a far better job on diagnostics. Too many children are not diagnosed. They don't know their status. Parents may or may not know how urgent the need is to come back to a site, or to use the opportunity of vaccine days, for example, to bring their children back, or regular maternal health visits that I think we'll hear a little bit more about in the second panel. But when you consider the cascade, and that's simply a series of steps, that prenatal, perinatal, postnatal, to provide proper care for a child, if we aren't able to diagnose the status of the child, the rest of the cascade doesn't happen for obvious reasons. Now, there are new technologies. I mean, it's not that no one thought of this before. There were challenges around technologies that are practical, affordable, trainable at scale in the field is the proposition, and that's going to be tested and rolled out, we think, within the next year, including because of some work that Unitate is doing around introducing these CD4 machines and painfully difficult to try and narrow it down to one thing to invest in. But at this point, we've got so many other tools that knowing the status of more kids and finding the incentives for them to return to care during the course of their first 3, 6, 9, and 18 months, we would see a dramatic uptick in the number of kids who are on treatment and a concomitant reduction in infant and under 5 mortality.
Pete, same question.
Yeah, and not that different an answer. 3 points that I think that from the Children's Investment Fund, building both on what Debbie and Chip have said. One is we've got to reduce the disparity that's emerging and becoming a really worrying trend between children on treatment and adults on treatment. And also just be clear that initiation on treatment is just not good enough. It is sustaining that. Our strategies at the moment from the SIF perspective are fourfold. One is we've got to basically change the unit of measure. We need to change the unit of measure from tracking mums, tracking children, to tracking mum-baby pairs. It's the early, low-hanging fruit that we're not simply doing. Totally agree with Chip. The biggest bottleneck currently that we see is on the absence of point-of-care diagnostic. Immediately for early infant diagnosis, but going forward for viral load if we're looking at viral suppression in the long term. I called Zimbabwe yesterday, and I'll hope have a little chance to talk about Zimbabwe. They've introduced in Zimbabwe a new central lab in Mutare, and it's next to the pediatric provincial ward. And it's fantastic decentralizing of central services. They're 100 yards apart. It takes 3 months to get a result for that child, notwithstanding the central lab being next door. It just says good, but not good enough. I think the other point is all points of contact. We've limited to date much of our work for ANC and some HIV/AIDS type clinics. That's great where we have huge ANC attendance. It's not great where we don't. So we really need to make sure that we look at all points of contact for children. 70% of the severely acute malnourished children in Zambia currently have undiagnosed HIV/AIDS status. Data showing us where the problem is. So one, the disparity issue. Second, I think we really need to be clear that we need to finish the global elimination plan. We've invested much, the success is there. There's some real challenging countries, but we need to get to the finish line, and I would argue not accept that 5% is actually the finish line, but as we get closer, actually look at zero infection. And I think the third point, which again is coming out, is that thanks to the stock-taking report and other analyses, many of you in the room, we have a new crisis on our hands that perhaps we haven't addressed, and that's around the new and increasing infections in adolescents, and in particular young girls. They're the 3 areas that I think, from a SIF perspective, that we're focusing on in the short term.
Can I maybe follow up with one question there? How was the decision made at your organization to make this a priority area for philanthropic investment? Why was this strategic? Why there were a lot of options there. What made this your focus?
For those of you who don't know, SIF, the Children's Investment Fund, is actually unique because of the business model. It's actually linked to a hedge fund called the Children's Investment Fund. You don't get many hedge funds called that. But we're close to about $4 billion in endowment now, so we're the second biggest foundation. The principles from the get-go really wanted to look at children infected and affected by HIV/AIDS. In one of their first visits, they actually came anonymously to USAID and held a discussion and basically asked people, what is the most unserved population that we have? And thanks to EGPAF and others, Raj himself, many people said this is an area you should invest in. But that simply wasn't enough. I think for SIF, it was also about trying to work out where we could make the biggest difference with our investment. And we wanted to look for an organization that had global technical competence, a large footprint on the ground, had some inspirational leadership, and was overtly supporting national government efforts, and that's why we chose EGPAF and also chose this area. Initially, much of the focus in the early days was on orphans and vulnerable children, with many of you in this room. That was the first group of investments. The second group of investments actually were with our colleagues in the Clinton Foundation. We were the largest funder for the Clinton Foundation and their pediatric and PMTCT work for a number of years. But it became very apparent that we weren't doing enough to stop infections in children. And unless we did, we would have an increasing mortgage of trying to treat them at later life. And so as we went up the value chain, more and more of our efforts went into PMTCT. And I have to say that the investment and CIF's investment in both Clinton and EGPAF were our two largest investments by a long way. And I'm happy to say that the Zimbabwe investment is outperforming virtually every investment we've made to date in terms of metrics.
Well, we're joined by our two panelists here, Shaffiq and Raj. And I was trying to think of some difficult or embarrassing question to punish you for being late. But actually, I'll just go back to where we began the discussion and allow you to make some overarching remarks on what investments do you think will have the most impact on the pediatric AIDS epidemic over the next 5 or 10 years? You want to start, Shaffiq?
Sure. Thank you very much. I apologize again for being late. Your metro system, your car system, it's all very confusing to we New Yorkers. Thank you very much for the invitation to speak at this policy roundtable and on such an august panel of co-speakers. I think from the perspective of the Clinton Foundation, our emphasis has always been on access. So I think we see several important critical access issues that need ongoing investment in order to be able to get to the next set of global targets that we want to achieve. You know, historically, diagnosis has, of course, been the entry point for pediatric care and treatment, and we've done a remarkable job in terms of scaling up previously unimaginable technologies like early infant diagnosis across the world in a number of countries. But we've sort of reached a plateau. With the current technology and the current model of service delivery, we've reached around 40% of access to infant diagnosis. And I think unless we break through that with novel technologies and newer approaches to service delivery, we aren't going to be able to reach higher than that 40% limitation of the current available platforms that we have. And the other key area, of course, is in drug development. We need to fund the ongoing procurement of drugs and other commodities that are essential for pediatric treatment. But we also need to, I think, go back to the drawing board a little bit and recognize that the drug landscape has changed. Global guidance has changed. And the drugs that we produced in generic formulations as pediatric fixed-dose combinations 5 years ago with the cooperation of CIF, many of the partners in this room, and of course FDA, many of those drugs are not any longer useful to us. These drugs contain stavudine. They contain fixed-dose combinations with nevarapine. None of them is a fixed-dose combination that has lopinavir in it. And yet we're seeing now that these newer drugs are becoming the backbone of global guidance around pediatric treatment. So I think without ongoing investment in the development of new drugs and in the development of child-friendly formulations of those drugs, we aren't going to see further increases in access. Our work at CHI has always been to try to create sustainable markets, and with pediatrics, that's especially challenging. So as we talk about investing in new formulations, let's also recognize that the number of pediatric manufacturers is very few, that in order to support them and give them the sense of sustainability in the market that I think is very important to keep them invested in this field, we have to actually provide ongoing efforts to sustain research and development by these manufacturers. Work that has been done by DNDi, for example, which is a non-profit agency that was funded by Unitaid to develop the soup to nuts of a new pediatric formulation, has really, I think, forged a new model for how we could do this. You know, they've taken the pain out of the process of developing a much-needed product. We have a list of these essential priority products that have been developed by global consensus around what's needed for future pediatric formulations, and we should be working through that list in a systematic way to invest developers to go ahead and produce them in a way that makes it sustainable for them while also maintaining a profit margin. And I think that's a real challenge that smart investments can make a big difference in. Thank you.
Raj?
Well, thank you, Michael, and thanks, Chip, for the invitation. And Deborah, it's good to be with you. It's also good to be with such a great panel. I am not an expert on the technical details of these issues. Dr. Ryan Phelps back there is, so you can put your hand up so folks can see you from our USAID team. So I'll direct all the tough questions to him. But I would just make a few points. One is, if it's true that 3 out of 10 eligible kids with HIV are successfully treated, then this community, which has done some extraordinary things over time, and with a really extraordinary level of resources and political support, has some opportunities to really improve targeting and support and focused engagement with children living with HIV/AIDS. So it strikes me that some of this conversation should focus on how do you get from 3 to an appropriate target number that's much closer to 10, if that's in fact where we are. The second observation is really around PMTCT and the activity in that space. We've all, I think, seen the great work of the Elizabeth Glaser Pediatric AIDS Foundation really champion and spearhead progress in so many different places. And I think you all know the examples of success extraordinarily well. It is probably worth just mapping and understanding where are pregnant women not adequately served and connected to systems, in part because, and I've heard Chip speak about this eloquently before, answering that question and bringing the resources and political engagement to resolve that question probably resolves a broader set of questions as well. It may help address the fact that too many women lack during their pregnancy adequate micronutrition and therefore have children who are predisposed to be stunted and malnourished at a time in their development where that will have lifelong consequences. Probably bringing them into some kind of a system where there's a dialogue around preventing transmission also helps to improve the percentage of women giving birth in assisted facilities or with support and real medical services around them, like we've seen in Zambia or Bangladesh or other parts of the world. And it probably could also serve as the point of the spear, so to speak, in order to build healthcare systems in resource-poor settings that preferentially prioritize women and children and probably also those who are least fortunate even within those settings. So it strikes me that in this space, having the technical focus and the ability to understand your target market, so to speak, can, and if you can dramatically improve performance in that target market, the upside is both addressing, maybe ending pediatric AIDS, but it's also building a sustainable public health infrastructure that can help accomplish, really the accelerated end of preventable child death and the accelerated end of preventable maternal death, so that you can start to see broader and more stable societies develop in places that currently suffer too much.
Just to follow up on that question, where do you put pediatric AIDS in USAID's child survival and maternal efforts, like the call to action? What's the context here?
Well, 2 years ago, and folks in this room were extraordinarily an extraordinarily important part of this effort, Shep and Anita and so many others. We were part of an effort that brought 80 or 90 countries together to really develop a results-oriented blueprint for how you would end preventable child death and, by corollary, preventable maternal death around the world. And tomorrow we will host the 2-year follow-on to that. Debbie, thank you for being there, because HIV/AIDS is central to achieving that goal. What we've done is we've gone through, with a panel of experts, we've gone through 24 high priority countries where 75% of under 5 child mortality exists, and detailed the specific sub-regions of focus and interventions required to most cost effectively save children's lives. And the big killers are the things are more like diarrhea and pneumonia, malaria deaths in some places, birth asphyxia and neonatal. In some places, pediatric AIDS rises to a top 5, but in many cases it doesn't. But that doesn't mean that it's not critical to the path, and that's why I made the second comment I did on the first round, which was, it is an area where we have resources and technical capacity and focus, and we're trying to reach vulnerable mothers and children who are at high risk. And if you can use that point of touch and that results-oriented focus to reach that target market with both AIDS-related antiretroviral therapy and with a package of pretty basic corollary stuff, then you are a big, big part of the fight to end preventable child death. And it's a vision that I think Jim Grant first made the world feel was possible to achieve. And now, I don't know how many years later, Chip, we are 20 years later, or maybe even more, we are able to actually quantify how to achieve that goal by 2030 in country after country. And we're seeing the countries themselves provide the leadership. So it's an extraordinary moment for us all to come together around a vision that is not new and a strategy that is not new, but perhaps an implementation rigor and a shared commitment to help each other out that is.
Deb, just to drill down on one point, give me an idea what PEPFAR has learned over the last decade about getting ARVs to children, and maybe what it needs to do differently moving forward.
Well, as noted in Zimbabwe, a 3-month turnaround time for early infant diagnosis is unacceptable. So we've spent a lot of time rolling out the tools that we haven't held anything back, waiting for the perfect. So we've gone with the good, in many cases, centralized testing. But we know in Mozambique, they've been able, through SMS, to get the testing back within a week. So we know that there's examples after examples of huge breakthroughs that we've asked countries to apply. So I think, the advantage of being in headquarters, you can see across all of the 60 countries that are PEPFAR countries and really look for those things that are key and then send those message out broadly. And so I think there has been a series of breakthroughs. We're really excited about point of care, viral load and diagnostics. That's long time coming, but we're excited that it's coming. I think the research that NIH has done in new formulations and in better options, absolutely key. I think we didn't have the right second and third line. We may not still have the perfect second and third line. We know that children fail second line quickly, so there's something wrong there. So we know that there's research yet to be done that we're strongly supportive of. We know that we need to do a better job with the tools that we have, and we're looking at that very closely right now. But I met Pete 2 or 3 years ago, and he kept saying to me, what's wrong with PEPFAR, and where's the data, and where's the metrics, and why isn't it visible, and what are you doing? And so
She's going to get her revenge now.
You go to PEPFAR.gov, all of the budgets by budget codes are up, so you can see exactly what we're spending in pediatric treatment, what we're spending in pediatric care, and within a few weeks the results will be up for every country over the last 10 years, because we really think we need additional insight from you all to help us do our job better. We know that we probably have 4,000 eyes on the problem, 8,000 if everybody has 2. But we really need 1 million eyes on the problem, and all of the different countries really looking at this and comparing country to country. I mean, there are some countries that have 60% of their children on ART, and they got there. So we need to quickly not wait for the publication, not wait for the abstract, but quickly connect through that data and having data instantaneously available so partners can connect, countries can connect, and hopefully we can get out of the way and facilitate those connections, because we think that those are extraordinary. So I think we've learned a lot, but we've not translated that into the global community where it can really have an impact. And we're very much dedicated to doing that quickly. And I know it's a vulnerability. I know that some of you will look at our investments and say, why did you do that? But that's okay. We'd rather have that vulnerability and have your insights than not have that vulnerability. And I think, so everything that the panelists have said have been correct, but there are countries that have succeeded in addressing this problem, and we have to really understand that and apply it more rapidly. I think we've taken longer to try to get to the perfect and not rolled out the good, and I think we're very much committed to rolling out the good as quickly as possible and address the diagnostic problem, address the nurse fear of seeing patients. It's huge. I know when Merlin used to take me into his clinic, I mean, I was supposed to be double boarded in pediatric and adults, and I was panicked in his clinic. So I had all my adult patients. I was calm. You know, small children are not little adults, and they have complications, and they don't like the taste. And every mother in the audience knows that if you have to hold your child down to get them to take a medication, or they immediately throw it up, there's a disincentive there.
Right.
And you really don't want to do it anymore. And now you're talking about doing it 365 days a year, every day. And then finally, and I think I'm so glad that the adolescent and young women piece came up, because the one thing we did learn in the United States is when adolescents get on medication, that's a dividing line. And so they may have been very adherent throughout their childhood and then stop their medication as adolescents. And we have to be looking for that, we have to be aware of that, and we have to put in structures to make sure that doesn't happen, because adolescents are a whole nother entity. And they're not either little adults or big children. They're a unique state.
No. They're alien.
Yeah. And sometimes I would have liked to have thought that.
Well, I have one.
You haven't met mine.
Chip, let me raise one issue. A lot of us are not scientists. We're more on the advocacy side.
Thank goodness.
And the question is, what role does advocacy play moving forward to make sure that children living with HIV, their needs are being met?
Well, at the risk of overstating it, I would say any significant response or accomplishment attributable or in response to HIV and AIDS is because of advocacy and advocates. We simply would not have been pushed into the actions and decisions and scale of resources were it not for civil society, for activists, and for advocacy. So there's an unassailable and profound role for advocacy. I'd go so far as to turn the question back around to you. How important was advocacy in making the case for President Bush, for example? We at EGPAF are proud of the fact that we played a role in trying to develop the support around the global plan, for example. 5 years ago, there was not a consensus around virtual elimination being set at 5%. There wasn't a global plan around which to rally ministers of health and so on. In Zimbabwe, and I don't want us to leave the room with the notion, or the one thing you remember about Zimbabwe is it takes 3 months to get test results, because Pete made reference to it before. The vertical transmission rate in Zimbabwe over the last 12 or 15 years has gone from 30 to 18 to 8%. And that's a result of a combination of continued work by the Global Fund in terms of its investments, PEPFAR investments, but it still didn't get us to where we needed to be. Additional, very substantial, in the spirit of transparency, $45 million over 5 years of promise? $45 million over 5 years of additional investments to go to take to national scale a set of activities, implementation, training, as mundane as vehicles and so on. That's what drove us allowed the Zimbabweans, we're outsiders of assistance, Using that as an example, advocating for that, every country is different. They might have 60% similarities, but such material differences that we can't say, take exactly what you did in Zimbabwe and start marching around and execute in other countries. But the model absolutely can tell us how, with additional investments on key priorities in key countries with the right conditions. UNICEF was instrumental in Zimbabwe, a number of other partners. That's what is achievable, and it's a combination of advocacy, resources, and it's trite to say it, but it's profoundly true, political will. At the end of the day, if the big boss wants this done and even wants it to be a part of his or her legacy, it's far. Why is Botswana where they are? Namibia, Rwanda, South Africa. At the end of the day, there's a critical change in political leadership that changed the calculation and the sense of accountability at, say, the cabinet level or within the media, among civil society. There's a partnership and a chemistry there that allows amazing things to happen. Absent that, it can be a slog.
Yeah. No, I strongly agree with that. I've seen from the inside in government that there are often advocates for this set of issues or other sets of issues, and they get empowered when it's a priority and the profile is raised outside the system. You're actually aiding people within the system who want to get this on the agenda. And that, I think, is an important relationship. I saw it on AIDS, I saw it on Sudan, I saw it on sexual slavery, some other issues where advocates have made a huge difference in making sure that there are always people, Republican, Democrat administrations, who care about these things, that want them higher on the agenda. And advocates help raise that from the outside. So
can I make one other, I'll call it an advocacy point, but it goes off a little bit. Raj commented importantly in response to your question about how to fit this into a larger child survival set of actions. There's an insidious effect in children not being diagnosed adequately. If you look at a UNAIDS, and I'm not blaming them, it's the data that they have, but if the pie chart for the principal causes of infant and under 5 mortality show AIDS at 2% or 3%, oh, then that's not a priority. But let's remember those kids are not being diagnosed. Pete talked about 70% of acute malnutrition in Zambia. Sorry?
Zimbabwe.
In Zimbabwe, are undiagnosed HIV positive. If a child is positive or exposed, has 3 bouts of diarrhea, attracts measles, has an acute respiratory infection, what's the cause of death at 3? Is it AIDS? Is it something else? And you can be almost guarantee that no one's in a rush to say, my child died of AIDS. So I believe that as an underlying condition, weakening obviously the immune system, but having other severely negative effects, opportunistic infections, other diseases, I think we're under-reporting and under-recognizing in the highest impact countries, in the priority countries, the underlying condition of HIV and AIDS in terms of infant and under 5 mortality.
Okay, we're going to go to questions at 10 o'clock, so be thinking of them just a few minutes, but I want to direct just a couple of brief questions before we get there. And the first question should be for Raj, because he has to leave, I think, a little bit early. What are some of the advantages of non-state funders when they're working in this space? What do they bring to this issue?
Money.
Yeah.
No, it sounds interesting, but you know, it really is interesting to see how little non-state funding is actually going into some of the main areas, whether it's the child survival agenda, the issues that Shaffiq mentioned, the research and development for new pediatric formulations. One would expect that there would be more, a plethora of models like the SIF model from the finance sector. But in fact, notwithstanding the sort of 10-year-ago dream that this was the new sort of nirvana for getting private sector dollars, most of us spend a huge amount of time in private sector collaborations that actually result in very little additional funds. And I don't want to belittle that, but it is important. In theory, I would like to think that we're more risk tolerant. In practice, I'm not actually sure that is the case. Having said that, I don't know many people would have put 45 million into Zimbabwe at the height of the oppression and the civil and human rights abuses, at a time when all hospitals and clinics were closed and people were being brutalized to leave the country. Not many people would have put that money on the table there. So I think there are exceptions. I think the other issue for the financing is that we can drive things that really mean a lot to us much quicker. And I do think from a SIF perspective and groups like us, we are fundamentalist in looking at evidence, data, and using data basically to drive outcomes. And we course correct, which is a very polite way of saying that we're hands all over the programs, and our colleagues in EGPAF are here, and others will know that they have the scars and the sleepless nights knowing what that means. But we are absolutely fundamental to know, what does the data show us? Are we using our resources most effectively? If things are not working, why? And ultimately, trying to make sure that every dollar counts. So we hope, bring money. 2, we can, in some cases, I think, take more risk, although that's not given. 3, private sectors prove not to be the nirvana. It's necessary, but not sufficient. And 4, I think in certain areas, whether it's the evidence generation, some of the research and development, or some of the issues about driving data and developing better metrics, I think we can. Certainly people like Gates are very heavily invested in technologies. And others. But I think that the issue has to be, ultimately, we need to fund gold standard organizations that have a proven track record of delivering results, and that's why SIF is happy to be here today supporting EGPAF.
Shaffiq, just one quick question before we get there, which comes out of this, but I'm just interested in your view, given your previous answer, about what innovation you see kind of coming down the pike that really right now needs some political and financial investment that could make a huge difference?
Yeah, that's a great question, and I feel a bit like a broken record. 5 years ago, 6 years ago, in fora like this, we would say, well, the real challenge is infant diagnosis. We can't identify these kids. And then the real challenge is appropriate child-friendly formulations. Well, the fact is, we solved those 2 challenges. We rolled out infant diagnosis at unprecedented scale. We developed a suite of child-friendly formulations. But guidance being the thing that it is, evolution happens, new evidence emerges, and now we're faced with a new set of challenges where we can say the same 2 things. It's early diagnosis and identifying the right formulations for kids. I see Debbie Prasad sitting in the front row, and if she had her way, we'd probably have kids being identified as newborns and being started immediately on newborn treatment. Right now, given the current technologies that are out there and commercially available, we can't do that in a public health setting. There's no way to get a rapid test of an infant in the maternity setting, and there aren't any suitable formulations that would be appropriate to give a neonate to be able to initiate that treatment. I think we all think that this is actually the way to go, not just because we might be able to achieve functional cure in some babies, but also because ultimately, in an infant, early treatment is actually beneficial for many, many reasons. It improves the survival of the immune system, enables more robust responses to vaccination. It has general effects on outcome and survival for that infant that are extremely important. So I think if I were to say let's push the envelope here, it would be around focusing on those newborns and figuring out ways using point-of-care technologies applied in the maternity setting, using smarter drugs, the same drugs that we use for treating older kids and adults, but just dosed in different ways, dosed using different approaches and formulations that could be used to be able to treat those newborns.
Great.
I think without investment in that area, it's not going to happen.
Let's take a few questions, maybe 15 minutes worth of questions here. So who would like to start? Please. And identify yourself, please.
Hi, I'm Craig McClure. I'm the chief of HIV at UNICEF in New York. And first of all, I just want to thank EGPAF for all of its work in the last 25 years and the extraordinary progress that's been achieved as a result of Elizabeth Glaser and as a result of all the people who've worked with EGPAF over the years. So, and thank you for putting on this seminar today. The comment I wanted to make, we talked in this panel quite a bit about new technologies, and there are incredible developments, as there have been in HIV and other areas of health for the last 25 years. We need to remember that in AIDS, the developments in terms of antiretroviral drugs, diagnostic technologies, and even the work in vaccine research, though we don't have a vaccine yet available today, have been extraordinary. And the pace at which those new technologies have become available has been extraordinary. We all know that the role of advocates and activists in making that happen has been extraordinary as well. But I think we shouldn't put too much emphasis on the needs for new diagnostics and new drug formulations right now. They will come. They are coming. There is energy. There is new momentum, again, for drug development and diagnostic development. We will have one day drug formulations that are long-lasting, that help kids and adults stay in care. I think we really need to focus on what can we do differently right now to get better results for children and their families. And different people on the panel really alluded to that. Debbie, you said, what are the tools we have now and how can we make them work better? One of the things you alluded to, Raj, is that, I guess the way I want to say it is, no child should be treated for common diarrhea with antibiotics and then go on to die of HIV-related causes. Similarly, no child with HIV should be treated with antiretrovirals and then go on to die for a vaccine-preventable disease, right? So to me, it's the approach, the way in which we support and strengthen programs in countries that focus on the whole child and her or his whole family, so that we don't just have kids diagnosed in postnatal settings where PMTCT is delivered, where kids are receiving HIV diagnosis through nutritional assessment, through platforms for sick kids in the community, in the facility, through EPI immunization programs. We need to really get real in terms of linking, aligning the services for children and their families, particularly in high prevalence, HIV prevalence countries, so that we do take that 39% HIV identified kids up to 70, 80, 90%, and those on treatment up to 80, 90%, and at the same time, make sure that they're receiving their immunizations, their treatment for diarrhea and pneumonia if they have it, their nutritional assessments and treatment for malnutrition. To me, this is the key around what we can do differently and how we can get better results now.
All right. Maybe Raj, can you respond to that idea of what we do now, not what the tools we're going to have in the future, but the examples like Deb was talking about, where some countries are doing this right. Okay.
Yeah.
About kind of what we can do in the present on this issue.
Well, I think that is a powerful answer to the question, which is, having a serious integrated platform to provide a basic package of appropriate diagnostic, prevention, and treatment services to pregnant women and young children is the solution. And the question is, can we come together across our different funding streams and implementation platforms to actually deliver that in setting after setting? And what I think which is why I spoke about mapping in my first comment. I think there are some settings where the mapping will not justify or will not allow for that kind of an approach. So for example, I think we looked at Nigeria, where you have very high levels of preventable child death and where you want to naturally drive focus to address that challenge through the broad suite of basic package of services, may or may not be places where you also have very high prevalence of HIV, particularly amongst pediatric populations. So it may not work immediately everywhere. But to Debbie's point about putting the data out there, if we had a mapping and could identify what are the sub-geographies where there is some overlap, that's then something we can do right now. That's then something where you could say where there's overlap between high under 5 child mortality in a country relative to other districts in the country, and high pediatric prevalence. And to Chip's point, it's probably high. It's probably more overlap than we think. We could visualize that, identify it, and insist on a comprehensive basic package for mothers and children in those settings. That's something you could do right now. I think it would make a huge amount of progress. I think it would demonstrate, as we've seen demonstrations in Zimbabwe and Zambia and Kenya and Senegal, that you can do this at scale and make a big difference. And I think, going to Chip's earlier point about advocacy, I think you also then would see a stronger country-led push to achieve success, because country leaders want to be able to address the full range of concerns that they face, and you're giving them an integrated solution to do that at relatively low cost, and in a manner that has some political weight, reaching women and children in particular. So I believe that's where you could focus your efforts, and if in a short amount of time you could have some big, powerful success stories around that integrated approach with real data to demonstrate the value, that would be a game changer.
Maybe Ambassador, do you want to fundamentally disagree with Raj?
No, I want to fundamentally agree, and I think we should do it tonight so we can have it ready as an announceable tomorrow for your piece. We're going to go back and scramble and work on that, because we have it done for HIV. We have all the subnational data, so it's like everything else. All of a sudden you find out when the study comes out that antiretrovirals prevent transmission, and we all go, oh. I mean, we should have known that for 20 years. When you lower your viral load to 0 and undetectable, you can't transmit the virus sometimes. But that is absolutely key, and I'm serious. We will go back today and work on that, because I think it's an absolute key announceable for tomorrow.
That's outstanding.
Wow.
Thank you.
That's news. So, Pete, you want to
clap? You're doing it.
Pete, did you want to add a point here? I know we want to get some more questions.
Yeah,
but
I just want to echo what the consensus is that clearly the momentum, as Craig and others and ambassadors and Raj have just said, is moving towards an integration. But let's also remember that Zimbabwe, 29% of the infant mortality was due to HIV/AIDS. The success of the mother-to-child program there means that it's no longer the number one cause. That doesn't mean to say the mother-to-child program stops and/or it isn't helping other issues. Right. The maternal mortality in Zimbabwe has dropped from 960, which went up massively from where it's based, to 550, primarily because we're keeping mums alive. The metric of keeping mum alive on other child survival is massive. We know that there's a 10-to-1 correlation between the death of the mother and the death of the child. The input of money into new cadres of health in Zimbabwe through the EGPAF PEPFAR SIF program, district focal points, they are now being used to address neonatal mortality. They are now being addressing maternal mortality. The integration is that governments don't sit there and say, we're only going to do mother to child, we're only going to do infant mortality, they are much more sensible than we are, and they integrate it in a much better fashion. And I do think that the underlying co-determinant of disease in high burden countries is important. And I do think as we get more sophisticated, using sub-data, national data to look at where the hotspots are, then I think we'll be even more sophisticated, because ultimately it's also about effective use of resources. And where we don't need to use resources at a national level, and we can target them at subnational and or key populations, then we should do so. But I'm really excited by the juxtaposition of what's happening here today, and that tomorrow we've actually got a celebration around the call for action and the promises renewed, because it's only together that we're going to achieve both goals.
We do a few more questions. Let's, someone else? Yes, please.
Hi, Emily Coomans, CDC. I'm really happy to see all of you on the panel. It's great to hear your responses. I'm interested in your thoughts on the cadres of health workers involved in moving these promises forward, and in particular, the large role of nurses that they have played in PMTCT and how they would play a role in pediatric HIV.
Who would like to take that?
We haven't talked much about human resources for health, but that's clearly an elephant in the room, one of the many. I think, my own experience from actually delivering services on the ground in many developing countries has been that nurses can certainly do an excellent job at providing this level of care. And I think, paradoxically, to echo Debbie's point earlier, an adult physician is probably less inclined to treat a child than a nurse who, in her training, has probably done maternal child health, worked on pediatric wards, certainly worked in a delivery unit as part of her general training. So I think we need a fundamental shift in our approach. And in a sense, this sort of echoes the comments that Craig was making earlier. We have tended to create for HIV something of a vertical program, at least for adult treatment delivery. And in the pediatric community, we were happy to sort of hitch our wagon to the adult HIV train as it was rolling down the track and said, us too, us too. And so now we have sort of verticalized pediatric treatment programs, often with specialists that are providing treatment, especially in large urban centers. We've ignored the fact that we had a large maternal child health program that was active in many, many countries, right down to the most primary level of service delivery, that was already providing preventative types of health services. And yeah, maybe it wasn't working as well as it should. Maybe it needed investment in order to make it function more effectively. Maybe there are certain sub-geographies and sub-regions where delivery of those types of services is very poor, but we have a mechanism that exists to deliver maternal child health services at the primary care level. We should be looking at proactive ways to unhitch our wagon from the adult HIV programs and sort of hitch it to the maternal newborn child health programs, which are nurse-led and nurse-run and nurse-managed.
Yeah, I think this gets back to the advocacy piece. We have to, and UNICEF I know is working on this, to get nurse prescribers in many cases down to the pediatric level is a policy change. And we have to work with governments about that policy change. Some of the, even in the adult clinics where I have been, some of the best physicians are the nurse prescribers, and they have really done an amazing job. But they are often, the policy does not allow them to do pediatric AIDS, and sometimes doesn't allow them to do B+. And so I think, Shaffiq, we've unhitched through B+, and we're right into the maternal child health blocks. But I think until we can get those policy changes, and I think we know what the countries are, and we should use the opportunity, both of the IAS and UNGA, to really readdress that, as well as the African Summit here, to really raise those issues around the core policy pieces that we need to get to that next step, because it's absolutely key. And we do have those clinics staffed with superb nurses. So.
Michael, I have to step out. I just want to say thank you for letting me be part of this. And I'm always reminded in these settings of how special it is to be in a room full of people who've committed their careers to this work. So thank you.
Thank you, Raj. Much appreciated. Shep, do you have a thought here? You want to introduce yourself? Everyone knows you.
Shepard Smith with the Institute for Youth Development. One of the early pieces of data that we saw that kind of drove us toward family-centered care was that the death of the father accelerated the morbidity and mortality of both the mother and child. And so we've had a lot of discussion about mothers and children, but the role of the father, I think, particularly in Africa, is extremely important. And anybody can respond to what we're doing to include fathers in dealing with infants and youth. Thank you.
Anyone like to respond on that topic?
Can I?
Sure, please.
I think that's a great point, and it's from our perspective, it causes a conundrum around contradictory data that we have. I think that when we were looking at the orphan, and many of the early orphan groups are here, one issue that staggered us in sub-Saharan Africa, where we came up with this issue about the double single orphan, was that when we did the demographics, 52% of the households had no resident male partner. So if the mother died, there was no other partner. And I think that created its own trajectory. The second piece of data, which again is worrying, is that the recent studies show that morbidity, mortality outcomes for exposed children, even when they're negative, is also worse for children, which creates a challenge in response. But in both cases, we have tended to not look at the male partner. And I think that in programs, and many more of the sophisticated programs, not only is it about track and trace the child, it's also about try and track and include the male partner increasingly into the program. And to be perfectly frank, in many of the programs that we've funded over the years, we've just not done a very good job.
Let's do one more question. Yes, please.
Hi, I'm Philip O'Brien. I work for the Elizabeth Glaser, at least until I ask this question, then never know when. A very experienced and very senior, respected colleague of ours was asked in public, he's a medical doctor, a number of months ago, what was the one thing, if he had to do one thing to end the epidemic, what would he do? And his answer was, end stigma and discrimination.
Yeah.
So my question is, do you agree? The panel agree with that? And if so, what are the implications for investments in that particular element of the addressing the epidemic? Thanks.
Who'd like to address that? Please.
So I'll just briefly, you're absolutely right. It was a barrier in the United States, and that's why I really wanted to open with that, because mothers were afraid to bring their children forward, even though they knew they were positive and the risk to their child was great because of the stigma and discrimination. Because when you couldn't have children go to school, when the other moms wouldn't let that child in play group, I mean, this was in the US, and we all experienced it. It's expanding in Africa now, and people think, oh, well, it's just that group. No. If one group is stigmatized against, everybody feels unsafe. And right now, everybody feels unsafe. Our partners feel unsafe in Uganda, Nigeria, and our patients feel unsafe. And we cannot ignore this situation. And I think we need everybody together to approach this as a human rights issue and acknowledge that we had our own issues in the United States, but we can't wait 20 or 30 years to reverse those cultural problems. We have to fast track it, and we have to figure out what that is. We're open to all suggestion. We've increased funding to local civil societies. We are coordinating through the faith-based organizations, which were extraordinarily important in the United States. And there are faith-based organizations that understand compassion and owning people that need help and support independent of how they became HIV positive or how they became ill. And I think we have to tap into all of those pieces to show the leadership in these countries that there are individuals that still have humanity and compassion, and the entire response to the epidemic will be derailed. This can unravel. We know, we've seen unraveling in Uganda. We can't afford unraveling. Unraveling and new positives means there's not enough money between the venture capitalists who have done a wonderful job, the private foundations, PEPFAR, Global Fund, and the host country, if our number of new infections double. So this is, you're absolutely correct. This is a problem for all of us, and somehow together, no matter who we see and who we talk to, we have to raise this as an issue and a real threat to the public health gains.
Well, that's a challenging place to end, about the way that human rights is essential to public health and many other things. So I think there was a lot of constructive agreement on this panel today, which I think was helpful. Maybe even a little news, which is interesting.
Everybody come back right now.
Right, right. And so please join me in thanking each of these panelists for their time today and their careers of service. Thank you.